please note down and see if you haven't, you don't follow me, or you think, oh, what is she talking? Go back and look at your lectures and redo them, right? So please see, first of all, are there a fat-soluble vitamin, water-soluble vitamin? First thing you should do is keep them separate. A, D, E, K are fat-soluble vitamin. They need fat for absorption. Any case of fat malabsorption, cystic fibrosis, pancreatic insufficiency, these vitamins cannot be absorbed and may be deficient. Though these vitamins are related to toxicity instead of deficiency, but still our lectures deal more with, so you are also more related to toxicity, but lecture clearly gives you deficiency. How would you formulate your fat soluble vitamin? You should know your provitamin if it has function. Then you should know active form if it has function and if it is used therapeutically. Because remember, you are doing these lectures clinically. And then deficiency. Although fat soluble vitamin are more for toxicity, still toxicity is not the big point of discussion in the lectures. So still concentrate on deficiencies. For example, vitamin D, provitamin is 7-dehydrocholesterol. You need sunlight, so you need cold climate. You may have deficiency of vitamin D. Active form, 1,25-dihydroxycholecalciferol. There are 2 hydroxylation, 1 in the liver, 25 in the liver and 1 in the kidney. That's why renal failure could also be history of vitamin D deficiency. So see, so many things you learn or you apply just from basic. So first go basic, provitamin, active form. Is there anything about active form? Deficiency. So when you say active form of vitamin D is 1,25-dihydroxycholecalciferol, what is it used for? To bring calcium and phosphate to normal in serum, right? And deficiency of vitamin D, rickets in children, osteomalacia in adults. So for example, if I say the function of vitamin D is that it's an antioxidant, is it true? Is vitamin D an antioxidant? Yes. No. So which is the primary? What do you think is an antioxidant? So yes, it's a no, but vitamin E, vitamin C. So see, there's a primary role. Don't flip-flop that. No provitamin if it has a role. No active form if it has a role or has therapeutic role or physiological role, and then do deficiencies. Keep them separate. I also want to give you pointers for these. Energy-yielding vitamins are low in chronic alcoholics, especially thiamine. So keep an eye on them. All of them, B1, B2, B3, they are also in TLC funds. So multiple vitamin-dependent enzymes, also keep an eye on them. Biotin is main also for energy, fat synthesis, acetyl-CoA carboxylase, right? And pantothenic acid is also for energy, activation of fat. So yes, they are energy-yielding vitamins, but then which enzyme uses them is very important. You must relate the vitamin, its active form, and to the enzyme, right? For example, NAD. Where would you see NAD? Just give me one enzyme which is linked to NAD. So you should know enzyme which they are linked to, and are they energy yielding? Are they hematopoietic or not? So what NAD is linked to which? So see, when I say NAD, isocitrate PDH, I like the answer PDH. Your order should be then PDH. Then why not isocitrate dehydrogenase, alpha ketoglutarate dehydrogenase? All answers are correct, but PDH should be on the top. Yes, your PDH, because it's a very important vitamin to start enzyme to start TCA cycle and energy. TCA cycle is a big cycle for energy, right? And it's common to all carbohydrate, lipid, protein. So PDH should be on your mind, please. But I like the list. I like the answer. Isocitrate dehydrogenase is absolutely wonderful. Yes, that too. Alpha ketoglutarate dehydrogenase. Then you should know macrocytic megaloblastic anemia, and you must differentiate B12 and folic acid. In the end, I will do microcytic. You people were also asking me. There's a differential table that is only for microcytic anemia. You don't need to know iron deficiency and lead poisoning, because I did that in the fall. I brought back B6 deficiency, right? Yes, now this is B complex, non-B complex, vitamin C. Don't forget that. Now let's see what is each role and why. As I told you, for provitamin, let's do quickly. Provitamin A, beta carotene. Any role? Any role of beta carotene? Any role of beta carotene? Beta carotene, anyone? What do you want to say? It is a major role, one major role. It's a provitamin A, but it's major role. We are doing provitamin, any role. Active form, any role, whether physiological or therapeutic. And then deficiency. Antioxidant, absolutely wonderful. Beta carotene is also an antioxidant. Vitamin E is an antioxidant. Vitamin C is an antioxidant. But then we will distinguish who is better than the other. Vitamin E is the best antioxidant, please. Why? I will tell you. Active forms, retinol, retinal, retinoic acid. Retinol for reproduction, retinal for vision. Retinoic acid acts at the level of nucleus, so it's for growth and differentiation, please. Helps in maintaining your epithelium, prevents epithelial keratinization. So retinoic acid also is all trans and 11-cis. Retinoic acid is the one which acts through the intranuclear receptors or intracellular receptors, just like lipophilic messenger. So it's unique. It's good to know it. So 3 forms, retinol, retinal, and retinoic acid. As I told you, there are retinoic acid, which acts through the intracellular receptor, helps in growth, differentiation, maintaining your skin integrity, preventing skin keratinization. Also, there are 2 forms of retinoic acid. 13-cis retinoic acid is teratogenic. It's not given to a pregnant female who comes for treatment of cancer. And all trans retinoic acid is therapeutic for PML. Do you remember PML, AML, M3? Which chromosomal translocation it is? PML, AML, M3. Chromosomes, 15, 17. Gene, 15 is PML and 17 is RAR. Oh, by the way, I was supposed to record this section too. Anyways, it's okay. We can record
Recording
now.
in progress.
Sorry. We can record now. So again, 15, 17, 15 PML and 17 RAR. Is it a fusion gene or gene under strong promoter? Is this a chromosomal a translocation outcome fusion gene? Absolutely wonderful. And what becomes oncogenic? The retinoic acid receptor. So see, you also, this is how you get good grades. When you say, okay, all trans retinoic acid therapeutic for PML, then do PML of cancer genetics also. This is how you get good grades. When you don't leave things like that and integrate with another lecture. Right? That's why I wanted to bring to your attention. Dry eye, xerophthalmia, increase dark adaptation time. That's vitamin A deficiency, right? Vitamin D, provitamin 7-dehydrocholesterol. That's why cold climate. You might have vitamin D deficiency because this requires sunlight. I told you 25 liver hydroxylation, 1 kidney, highly controlled. This one regulation. What's the function of vitamin D? To bring calcium and phosphorus to normal, right? To bring calcium and phosphorus to normal. Does parathyroid hormone works in conjunction to vitamin D? Absolutely, except parathyroid hormone promotes phosphate excretion at the level of parathyroid hormone promotes phosphate at the level of kidney. Right? So yes, vitamin D deficiency leads to rickets in children, osteomalacia in adults. The major role of vitamin D is to bring back an active form is 125 dihydrocholecalciferol to bring serum and phosphorus back to normal if they go down. Right? Parathyroid hormone works with vitamin D except at the level of kidney. It promotes phosphate excretion. This was remember last time when we discussed that there was a wrong answer. In rickets, bow legs, poor mineralization is vitamin D deficiency. Vitamin K, it helps in activation of clotting factor 2, 7, 9, 10. History, because this activation actually vitamin K causes activation of clotting factor 2, 7, 9, 10 by doing what? Hydroxylation, carboxylation. How does vitamin K activates these factors 279 by gamma glutamate carboxylation of 27910 and helps in clotting. Now, sometimes vitamin K deficiency confuses students between vitamin C deficiency. Vitamin C deficiency is superficial hemorrhage and delayed wound healing, but vitamin K deficiency is deep internal bleeding, easy bleeding and bruising, along with that prolonged prothrombin time. So then you know it's vitamin K deficiency. Can it happen in premature infants are prophylactically given vitamin K because premature infants' liver is immature. This is all happening in the liver. Or chronic alcoholics. Alcoholics may also have prolonged prothrombin time because of liver damage. So the liver site is important. Vitamin K is important for activation of clotting factor, increase in prothrombin time, internal bleeding, easy bleeding and bruising. That's not vitamin C deficiency. That's vitamin K deficiency. Vitamin K, gut sterilizing antibiotics. Sometimes we don't acknowledge the other minor source of vitamin K is your gut bacteria. So gut sterilizing antibiotic is also a history of vitamin K deficiency. Premature infants, they may have vitamin K deficiency because of immature liver system. But gut sterilizing antibiotics is also one of the history of vitamin K deficiency. Vitamin E, most potent. Tocopherol is just the provitamin. Tocopherol is addressed with vitamin E. Why it's an important antioxidant? Because number one, it breaks the chain of free radical. It's not like superoxide dismutase, catalase, that it only neutralizes one free radical. It breaks the chain of free radicals. Secondly, it prevents membrane peroxidation. Now, this is very, very important for you to maintain membrane function. Otherwise, you will lose receptor. There will be membrane rigidity. So these are two very important role of vitamin E as an antioxidant. It neutralizes a series of free radicals, not just one chain of free radicals, and prevents membrane peroxidation. So where I am taking you to is there a provitamin? Is there a role? Like beta carotene is antioxidant. Are there active forms, their clinical or physiological role? And deficiencies. For example, in vitamin E, I told you physiological role. Vitamin E deficiency leads to hemolytic anemia. So this is about fat-soluble vitamin. Let's go to the water-soluble vitamins. I told you, are you following my pace? Because I'm trying to quickly give you a pointer. Is this helping? Absolutely wonderful. So now vitamin, for water-soluble vitamin, you have non-B complex and B complex. B complex, I told you clearly, know the energy yielding because chronic alcoholics suffer from vitamin that are energy yielding. That's why they're always drinking and sleeping, right? And their brain doesn't function well too. Then you should know microcytic, hematopoietic, macrocytic anemia, and microcytic B6, right? These are your water-soluble vitamin. Non-B complex, B complex. Non-B complex, vitamin C, B complex, energy yielding, which are very low in chronic alcoholics. They are not, because they have vitamin deficiency, do not eat well. And macrocytic, microcytic anemia. Macromegaloblastic anemia, folate, B12. Microcytic, B6 deficiency. Right? Is that clear? Yes. Now, there is no provitamin. There is no toxicity here. There are only active forms. So only thing is you don't make a mistake. For example, what is the active form for riboflavin? Is it NAD, NADPH or FMN, FAD? Active forms of riboflavin. Is it NAD, NAD, FAD, FMN and FAD? So first don't flip-flop that. Then you see which enzyme they are being used. Right? Step and pathway may not be, if very rare. Enzyme, yes. That's why it's at the top, right? In the front of the train. And then deficiency, anyway, they are not related to toxicity. And I've clearly given you an example that where NAD is used, where NADPH is used. So can you give me one pathway where NADH is used? Or maybe two pathways? If we talk about pathways where NADH is used, NADH, pathway. See, when I'm saying pathway, you don't answer enzyme. TCA cycle. What else? NADH, who said HMP? That's a wrong answer. Is there NADH or that is NADPH? Glycolysis and TCA you have done NADH. NADPH is HMP shunt. Fatty acid carboxylation. You mean acetyl-CoA carboxylase? No. All carboxylases require biotin. All carboxylases require biotin. No. NADH means I like that answer, glycolysis and TCA pathway, right? NADPH is, yes, absolutely wonderful, HNP shunt. So either enzyme, first enzyme, or if you know the pathway as I asked you. B complex, one mistake students make is they are always towards vitamin C, hydroxylation, collagen strong, weak collagen, bleeding gums, and falling out of teeth. But they don't but they forget that there are two other important roles of vitamin C. It's an antioxidant and it helps iron absorption in the form of Fe+2. That is why vitamin C deficiency also leads to microcytic or macrocytic anemia. Vitamin C deficiency can also lead to microcytic anemia. So yes, collagen strong, absolutely wonderful, but scurvy sign, which is vitamin C deficiency, signs are not prolonged prothrombin time, easy bleeding and bruising. No, it's just a superficial hemorrhage, bleeding gums, or poor wound healing, right? But don't forget the other roles of vitamin C, which is antioxidant and helps in iron absorption. That is why vitamin C deficiency may also lead to microcytic anemia, right? So see, we have already identified so many antioxidants so far. What antioxidants have we identified so far? Anyone? What antioxidants have we identified so far? We identify vitamin C, vitamin E, and beta carotene, see? But then they have different roles. As vitamin E, and which is the actually most potent antioxidant, vitamin E. You know collagen, vitamin E. Most potent antioxidant is vitamin E. You know this making strong collagen, vitamin C. If there is vitamin C deficiency, there could be scurvy, bleeding gums, falling out of teeth. Why do you need to know clearly these two different lists? Because chronic alcoholics suffer from these energy yielding vitamin dependent enzyme, right? So vitamin dependent, and only measured is trans ketolase, right? Now, where was alpha ketoglutarate dehydrogenase? Which pathway? Alpha ketoglutarate dehydrogenase. It shares the same vitamin as PDH. Alcoholics suffer from PDH deficiency. Alpha ketoglutarate dehydrogenase is in the TCA cycle. So is alpha ketoglutarate dehydrogenase only thymine dependent or is TLC fun? It's only thymine dependent or is it TLC fun? It's TLC fun. Yes, all of them. But still they are recognized as thymine dependent enzyme. PDH, very important energy yielding enzyme, dependent on TLC fun, thymine deficiency, chronic alcoholics, which is that step where is PDH 3 or 4? Where is PDH 3 or 4? 3 or 4. Where is PDH? 4. 3 is pyruvate. What is 3? What is 3? What is 3? Pyruvate. Which vitamin it requires? Pyruvate carboxylase. Which vitamin? Biotin. So which vitamin? Vitamin, active form, which enzyme? If you know the pathway, absolutely wonderful, right? For example, if I'm saying, if you're saying alpha ketoglutarate dehydrogenase, which pathway? You just told me TCA cycle, right? You told me alpha ketoglutarate dehydrogenase, TCA cycle. Now, what was the question here? You have B5, TLC fun, remember? TLC fun, B5 is a CoA. So which enzyme is thymine and multiple vitamin dependent? Both thymine and multiple vitamin dependent. Are you aware of this enzyme? PDH, yes, which is important for TCA cycle to start. Once TCA cycle is started, you have so many vitamin C. Is this multiple vitamin dependent? Is this multiple vitamin dependent? Is this multiple vitamin dependent? No, it's niacin dependent. Is this multiple vitamin dependent? Yes, absolutely. You got to understand, are they thiamine dependent? Are they multiple vitamin dependent? Or are they only one vitamin dependent? Now when you see malate, for example, malate dehydrogenase, does it require riboflavin? Does this step require riboflavin or vitamin B2? No. So it's a very clear list. You know clearly where is your riboflavin, where is your niacin. Does this enzyme require riboflavin? Does this enzyme require riboflavin? Who's saying no? TLC fun. This is TLC fun, right? Yes, so this also requires riboflavin, but this does not require riboflavin. You understand my point? Malate dehydrogenase does not require riboflavin. This requires riboflavin. Just a second. Why not? Alpha ketoglutarate dehydrogenase share the same vitamins as PDH, which is TLC1, right? Yes. Where is this FAD coming from? Where is the FAD coming from? FAD, FMN, they come from which vitamin? Vitamin B2, right? So the vitamin, their coenzyme form, which enzyme is important, and then the pathway, right? Dietary thiamine deficiency, very, very. Chronic alcoholics also suffer from thiamine deficiency. What is the typical triad of thiamine deficiency in chronic alcoholics? Ophthalmoplegia, they stare at one point. There's ataxia, there's encephalopathy. If you don't solve thiamine deficiency in chronic alcoholic at vernix levels, then they go into psychosis. This is not very easily reversible. Confabulation, making false story. That's not a good stage to revert thiamine deficiency. Yes, you give thiamine and glucose. So you do talk about thiamine deficiency in chronic alcoholics. Now, why does thiamine deficiency leads to all these brain fogging for function? Why? Why does all the thiamine deficiency leads to all these kind of brain fogging function? Because the brain is primarily dependent on what? PDH is not working and brain is primarily dependent on not lack of keto. What is keto? I'm asking in thiamine deficiency, why are there so many brain affected function? Somebody answered very well that brain primary energy is glucose. If PDH is not working, glucose is not being utilized, so they can't function properly, right? Right? Does that make sense? Because of primary source of brain as glucose. So here, now I'll ask you, is this thiamine deficiency? So why, let me ask you, why this is not the right answer? Why this is not the right answer? Please, I'm not going very slow also. I'm not going very fast also. Is the space good? Yes. Is the space good? It's good? Right. So why this is not the right answer? Why trans ketolase is not the right answer? But deficiency, even trans ketolase should be affected. Because they are asking energy. Yes, absolutely wonderful. I like that answer. It's nothing to do with energy, and they're asking energy deficit. Otherwise, this could also be the right answer. But trans ketolase is for HMP shunt. HMP shunt is not for energy, so this is the right answer. Energy deficit is for PDH, right? So you know chronic alcoholics, thiamine deficiency. So in thiamine deficiency, trans ketolase can also be affected, but trans ketolase is not for energy. Trans ketolase is HMP shunt. It's not. Nothing to do with ATP. Riboflavin, you know riboflavin in TLC fun. So go and see where riboflavin is. For example, I asked you, malate dehydrogenase in TCA cycle needs riboflavin? Malate dehydrogenase? No. So you can link the wrong enzyme and wrong vitamin. You understand where I'm taking you? Very non-specific symptom. It's not like pellagra and which is niacin or beriberi. Non-specific symptoms, glossitis, cheilosis, angular fishing. right? So right vitamin, right enzyme. So is riboflavin for energy yielding? Yes or no? Absolutely wonderful. So why? Yes. So why A is not the right answer? Is riboflavin not for hemoglobin synthesis? Why A is not the right answer? So what is it? Who is required? So now you see when you say, can we have more questions? Well, you have 5 concepts here only, right? Rule out. I'm telling you, when you do questions on my on the review PowerPoint I have shared, please rule out every answer. Does that make sense? So I was asking you why A is not the right answer. So hemoglobin synthesis does not require folate of B12. First, hemoglobin synthesis requires anyone? Hemoglobin synthesis B6. B6 is directly involved in hemoglobin synthesis. All right. Yes, folate and B12 are involved in nucleic acid synthesis. Purine, pyrimidine, methionine, right? Does that make sense? Heme synthesis B6. So rule out every choice. Every question you can learn 5 concepts and answer 5 questions on the test, right? They are there for a purpose, right? B3 niacin. Niacin is NAD, NADP. Clearly, niacin deficiency is pellagra, diarrhea, 3Ds, diarrhea, dermatitis, dementia. So when I'm saying niacin dependent enzyme, can you give me names which are niacin dependent and for energy? Niacin dependent and energy yielding. PDH, alpha ketoglutarate dehydrogenase, malate dehydrogenase, isocitrate dehydrogenase. So many names you can get. Yes, brand change should come last. Very good. I like that answer. Absolutely wonderful. Brand chain is also there, but PDH should come to you. When I say niacin, niacin dependent enzyme, energy yielding PDH, alpha ketoglutarate dehydrogenase. Brand chain, why not? But PDH, alpha ketoglutarate dehydrogenase first, right? Right? Because they are for the major PDH and alpha ketoglutarate dehydrogenase are for major the TCA cycle. PDH helps entering TCA cycle, right? Right? PDH will help in starting TCA cycle, yes. And alpha ketoglutarate dehydrogenase is for TCA cycle, right? Diarrhea, dermatitis, dementia. Let's go further quickly so we can finish our review. Dermatitis here is in sun exposed area, NADPH. Now, is this for energy? Is NADPH for energy? It's also from vitamin B3 niacin. No, it's for synthesis. It's not for energy. It's for synthesis, right? So vitamin, active form, enzyme, pathway, if you know them, but then history is important, like gut sterilizing antibiotics. What are you thinking? Gut sterilizing antibiotic. Which vitamin will be deficient? Vitamin K. Cold climate. Cold climate. Vitamin D. Similarly, polished rice. Polished rice. Eating polished rice. Anyone? Thiamine deficiency. Thiamine deficiency, polished rice. And here, corn maize, corn as a staple diet is associated with the niacin deficiency, pellagra. Right, cystic fibrosis. What vitamin will be deficient? Cystic fibrosis. It's important, but in boards. But why not at least? Who will answer me? Fat soluble, absolutely wonderful. Very, very good. Very important, right? But for boards, why not? You should also have good information. Uh, CoA, activation of fat, part of TLC fun. Is it for energy yielding too? Pantothenic acid B5 CoA. Is it for energy? Absolutely. It activates fat to enter any pathway. So for energy yielding. So what is my vitamin? What is its active form? So B5 active form is sorry. For B5 active form is sorry. I lost power in DO session, so please be mindful. It comes back. I don't know why it's so quick in India. So, but if it goes, bear with me. So sorry, I just gave you the answer. What is active form of B5? CoA, absolutely wonderful. So vitamin, active form, and where they are present. Biotin for carboxylation. Give me 2 carboxylases that require biotin. Just 2, maybe 1. carboxylase, that enzyme. You should know the enzyme they are linked to. Then only you will know what pyruvate carboxylase, that's all. Acetyl-CoA carboxylase. Is vitamin K carboxylase dependent on biotin? There's a vitamin K. Vitamin K. Vitamin K dependent carboxylation, clotting factors 2, 7, 9, 10. Does that carboxylase require biotin? No. It requires vitamin K. Remember? Carboxylation of 2, 7, 9, 10 in the liver, gamma carboxylation, that is not biotin, that is vitamin K, right? It's different. So you know what should be your biotin, should be carboxylase require biotin. Very good, very excellent. Pyruvate carboxylase, acetyl-CoA carboxylase. So is biotin for energy yielding also? Is biotin energy yielding too? Yes, because it's required for acetyl-CoA carboxylase, fatty acid synthesis, right? They say raw eggs, more than 20 per day. I hope no one does that. Eating raw eggs lead to biotin deficiency, non-specific also, but they have these orofacial rash and alopecia, losing hair. That is biotin deficiency. People were asking me answer to these questions. These are more higher order question. Biotin, is pyruvate carboxylase, right? So pyruvate carboxylase deficiency will lactate build up. In pyruvate carboxylase deficiency like PDH, will lactate build up? Yes, so lactate competes with urate for excretion, so hyperuricemia is the right answer here, right? This is, I think, very high order question, but I think I don't teach DOs and masters differently. So these are good questions for you to ponder too, right? That why is biotin deficiency carboxylase leading to hyperuricemia? Because in biotin deficiency, there will be lactate accumulation. Here, biotin definitely has hypoglycemia, right? Biotin deficiency. Will pyruvate carboxylase work? No. Biotin deficiency. So what will happen? Hypoglycemia, right? So if you know the pathway, it's okay. But first, you should know vitamin and enzyme. For example, biotin, you said pyruvate carboxylase. But if you say it's for gluconeogenesis, much better. But at least you know the enzyme, right? Does that make sense? I first want you to know vitamin, water-soluble vitamin, active form, which enzyme, and where it will be deficient. So are you clear so far which enzyme and where? Folic acid and B12, absolutely wonderful, because this is where people go wrong with homocysteine and methionine. I have done a TBL too. TBL is for case discussion. So again, I'm telling you. So many people panicked with that. So, but microcytic anemia is B6 deficiency. Why? Why microcytic anemia is B6 deficiency? B6 deficiency is microcytic anemia. Why? Where is B6 required? Because of lack of iron? No, not in heme synthesis. It's not with B6. That's with vitamin C. I'm talking about B6. B6 leads to microcytic anemia because B6 is required for heme synthesis. Now, vitamin C deficiency leads to microcytic anemia. Why? That was the answer, that lack of iron absorption. So see, be mindful. Pyridoxine deficiency can also lead to microcytic anemia, and vitamin C deficiency can also lead to microcytic anemia. Causes are different, right? Does that make sense? Is it clarified now? Yes? Great. Macrocytic anemia, folate and B12. We will do a good differential between folate and B12. And right now, B6. B6, heme synthesis. Please do B6. Please do B6. Also, I will tell you, please do B6, because right now you flipped it. B6 deficiency, microcytic anemia, no heme synthesis. Vitamin C deficiency, microcytic anemia, no iron absorption. But do B6. Just like carboxylase require biotin, decarboxylase require anyone? Just like all carboxylase, not vitamin K dependent carboxylase, but all carboxylase require biotin. What does decarboxylase require? Anyone? B6, 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 B6. Yeah, somebody said B6. Yeah, look at it here. B6 decarboxylation, right? Just like all carboxylases require biotin, decarboxylases require B6. B6, learn it well. You just flipped it. So I'm telling you, go back and do B6. Okay. B6 microcytic anemia, also known as sideroblastic anemia. We are not doing pathology here. Dr. Bannon and Dr. Brown will cover that. We are only covering vitamin. Did I say B6 deficiency leads to microcytic anemia? Here it is. You don't need to do this pathway, but don't forget to bring back your fall with B6 deficiency here, right? B6 deficiency can lead to microcytic anemia because it's involved in heme synthesis. Same reason is not for vitamin C deficiency leading to microcytic anemia, right? Hemoglobin synthesis here requires which vitamin? Hemoglobin synthesis, pyridoxine. So what should have been with vitamin E? What should have been the role here if it was vitamin E? Anyone? It's not an antioxidant, absolutely. So you got to remember the primary vitamin, its active form and primary role first. Does that make sense? Secondary later. Though for non-B complex vitamin C, I did tell you collagen is the primary role, but what was the secondary role? Antioxidant and iron absorption, right? But still primary. Sorry, so primary still should come first, right? B6. Vitamin E primary is antioxidant. Only B6 deficiency. Somebody asked me, why did I have the chart? I just didn't delete the iron deficiency and lead poisoning, but this chart is because of B6 deficiency. B6 deficiency leads to microcytic anemia. I want you to relate B6 with heme synthesis, right? Is that clear? Everybody is good? Right? Good so far? Now let's do folate and B12. Students are highly confused with these two vitamins. When it's clearly folate of a vegetarian diet. Actually, it's opposite in B12. Vegetarian diet leads to B12 deficiency, number one. Does that make sense? Number one, this. Now, where they are involved. Folic acid is required for purine synthesis, pyrimidine synthesis, and methionine synthesis. Are you clear with that? First of all, vegetarian diet is a source of folic acid. That's why pregnant female are asked to eat good green leafy vegetables. But vegan diet, on the contrary, is leading to B12 deficiency. That's why those who are vegetarian or vegan, they are advised to take B12 supplements or injections, right? Right? So two opposites. Secondly, where is folic acid required? Purine, pyrimidine, and methionine synthesis. Now tell me, where is B12 required? I told you where folate is required. First, normal to abnormal. Where is B12 required? B12 is required for? Tell me, give me. I said folate is for purine synthesis, pyrimidine synthesis, methionine synthesis. B12 is, you can't ignore that B12 is also required for nucleic acid synthesis. B12 is required for, you cannot neglect that. B12 is required for nucleic acid synthesis, but B12 is required for methionine synthesis. What else? Folate, I gave you a list. Purine synthesis, pyrimidine synthesis, methionine synthesis. Is this list complete? B12, nucleic acid synthesis, methionine synthesis. Yes, somebody very well addressed is the methylmalonyl-CoA, succinyl-CoA pathway. Please, first of all, do not relate folic acid to that pathway. Folic acid has nothing to do with propenyl-CoA, methylmalonyl-CoA, succinyl-CoA pathway. Right? Does that make sense? Are you clear with that? Right? Active form then of folic acid, tetrahydrofolate. I clearly told you folic acid is required for purine, pyrimidine, and methionine synthesis. The problem now comes is the deficiency. Now, folic acid deficiency is because folate is not present in the diet. Yes? Yes? But B12 deficiency also leads to folate trap and the same signs and symptoms. Do you understand this? Low folate in diet leads to folic acid deficiency. But B12 deficiency, folate is okay. The folate is sufficient in the diet, please. But there's a folate trap. Folic acid is trapped. So same signs and symptoms. like megaloblastic anemia. First, are you clear with that? Right? Yes. B12 deficiency, is there anything wrong with folate? No, absolutely no. In B12 deficiency, there is folate trap. Folic acid is not available to do the purine, pyrimidine, or methionine synthesis. Are you clear with that? Number one. Then clinical finding. How will you assess folic acid deficiency? Do the folate levels. How will you assess B12 deficiency? See the B12 levels. In each one of them, there should be low. Again, as I said in the case, borderline is also low, please. It's not a normal. Borderline could be low borderline, high borderline. They are not good. They are also, they alarm the physicians. This is not correct. So they are not normal. So again, so are you clear with that? Do folate levels low, do B12 levels low. Now we'll go further and differentiate them. Does that make sense? So folic acid, there is no purine synthesis, no pyrimidine synthesis, no methionine synthesis, because folate is not present in the diet. But in B12 deficiency, there is a folate trap. So same outcome, no purine synthesis, no pyrimidine synthesis, and no methionine synthesis. So then how will you differentiate? This is very important two reactions or pathway that help you differentiate. Now, folate and B12, folate and B12 is required in pathway 1 or pathway 2. Folate and B12 is required in pathway 1 or pathway 2. Folate together with B12, pathway 2. So folic acid and B12 deficiency, what will happen to homocysteine levels? Folic acid and B12 deficiency, what will happen to homocysteine levels? High, absolutely wonderful. What about B6 deficiency? Will the homocysteine levels be high? Yes. So folic acid and B12 deficiency, homocysteine is high. Pyridoxine deficiency, homocysteine is high. So that's not differentiating. So tell me what levels are differentiating folate B12 from B6? There's always one differentiating levels. Not MMA, not MMA. There's no MMA here. You are always going to MMA. MMA differentiates folate from B12. I'm not asking you that question. I'm asking you folate, B12, and B6 deficiency, since both homocysteine will be high. Methionine level, absolutely wonderful. So in which deficiency? So in pyridoxine deficiency, what will happen to methionine levels? High or low? High, because this pathway will be diverted to this one, right? So here you got to understand what is common, what is differential. When you discuss homocysteine B12 from pyridoxine, what is common? Homocysteine is high. What is differentiating? Methionine. Methionine will be high in folate B12 or pyridoxine deficiency. Folate B12 or what? Or pyridoxine. So are you clear with this first? Right? How you keep differentiating. This is how you will go to a diagnosis even in your clinics. So homocysteine metabolism required folate, B12, and B6, all of them. I just showed you, right? Right? Is the statement true? So do you understand macrocytic versus megaloblastic anemia? Right? Have we done folate and B12 macrocytic, vitamin C and B6 microcytic? Yes. Are you clear with that? Folic acid deficiency and B12 deficiency. So let's see, folic acid and B12 deficiency. Megaloblastic anemia is differentiating. Is megaloblastic anemia? No, both of them you see megaloblastic anemia. High homocysteine levels are differentiating. Folic acid versus B12, no. So keep doing this. This is folic acid and B12 deficiency. What is differentiating? Is neurological signs and symptoms like paresthesia, tingling, numbness differentiating? Yes. Where is it seen? Folic acid or B12? B12 only. Neural tube defects. Pregnant female. Is this differentiating? Folate. So see, there are some findings on folate, some findings in B12, high homocysteine levels, homocystinuria. This is not differentiating. Then do what is differentiating, right? Does that make sense? So this is how you have to do folate versus B12. See, neural tube defect, anencephaly, spina bifida, if pregnant female is not taking adequate folate. Sometimes it happens because the female doesn't even know that she has conceived and may take longer time to take the folate. Sometimes it happens then too. One thing I was bringing to the attention, but I think it slipped from my mind, which was very important. Can I go back? What was I trying to? It will come, it will come. Now, B12 deficiency. B12 deficiency, vegan diet. Why partial gastrectomy? Intrinsic factor. I'm just telling you history. Ileum resection, B12 is absorbed at ileum, ileum resection, partial and total gastrectomy, vegan diet, this is all B12 deficiency. So that is differentiating, right? Why gastrectomy is B12 deficiency? No intrinsic factor. Intrinsic factor is essential for B12 absorption. And B12 deficiency due to intrinsic factor defect is known as, there's a name, pernicious anemia. Absolutely wonderful. You are giving great answers. I hope we hit the highest average this time, right? Hope so, right? We are working hard, right? So great. Pernicious anemia, absolutely wonderful. So this this pathway you don't think about folate, please. That's what I was asking. This pathway is not folate dependent. So first, normal. Where is folate used? Purine, pyrimidine, methionine. Why B12 also, when there's folic acid deficiency, purine is gone, pyrimidine is gone, methionine is low. Why in B12 also they all are low? Because in B12 deficiency, folate is normal in diet, but there's a folate trap. So all of them are affected. So is megaloblastic anemia differentiating folate from B12? Is this pathway differentiating B12 from folic acid? Absolutely. So in folic acid deficiency, what happens to MMA? There's no borderline there. In folic acid deficiency, normal. In folic acid deficiency, MMA will be normal. Okay, yes. Thank you. Thank you. We are good. We are at a good pace. MMA is normal in folic acid. That's I think I was thinking what I wanted to tell you. So in folic acid deficiency due to low folate in diet, you are not doing nucleic acid synthesis. In B12 deficiency, because of folate trap, you're not doing nucleic acid synthesis. So nuclear maturation lags behind cytoplasmic maturation. That is why you have cells with large nuclei, which are known as macrocyte or megaloblast. That's why you see macrocytic or megaloblastic anemia. Right? B12 deficiency, macrocytic megaloblastic anemia. You will not see, in folic acid deficiency, MMA levels would be normal, right? Also, why in B12 deficiency is folate trap? This reaction is blocked in B12 deficiency. You cannot form free tetrahydrofolate. This is a very important reaction for forming active form of folate or free tetrahydrofolate. You can be eating so much folate from diet, right? You get folate from this reaction mainly. And this is blocked in B12 deficiency, which simulates that folate is not functional, right? Folate trap means folate is not functional. So are you aware of folate trap, which is seen in B12 or folic acid deficiency? Folate trap. B12 deficiency, both folate and B12, can they both lead to low SAM? Can be both folate and B12. That also leads to some of the neurological signs and symptoms, but the typical paresthesia, numbness, tingling is mainly because of that vomit. Remember the propenyl-CoA, methylmalonyl-CoA pathway? Those intermediates actually, they accumulate and cause neurological damage to the nerves. Now, vegan diet is folic acid. Yes, vegan diet. Right? It's folic acid. And what is it required for? You know, folate is required for purine, pyrimidine, and methionine. Synthesis is folate required for MMA metabolism, methylmalonic acid metabolism. Is folate required for MMA metabolism? Is folate essential for MMA pathway? Propionyl coenzyme? No, it's not. So don't bring that there, right? If you want to get good grades. Again, megaloblastic anemia, malabsorption. Why? Because of the intrinsic factor. And I remember I asked you this question in the class. How will you know that megaloblastic anemia is because of intrinsic factor defect or absorption is a problem rather than vegan diet? Because of anti-intrinsic factor antibodies. There's slow DNA synthesis. You know that nuclear maturation lags behind cytoplasmic maturation. So that's all for today. I did cancer genetics, right? Now the floor is open for questions if you have, right? Great. Yes, tell me what's your question. If you have a question, you can stay. If you want to listen to the questions, absolutely. Yes, tell me, Jess. What's your question?
So what is the difference between microcytic anemia and sideroblastic anemia?
So microcytic anemia can be sideroblastic. Now, microcytic anemia is sideroblastic. Why in B6? If you go back, B6 deficiency is required for heme synthesis, right? Let's go back to the heme synthesis, and I'll show you exactly why some microcytic anemia are also sideroblastic. If you see B6 deficiency, let's go to this B6 deficiency. Very good. Yeah, sure. You're welcome. If you see B6 deficiency, in B6 deficiency, there's slow heme synthesis. Yes?
Yes.
Is iron being used here, which is in the last step? Can iron be used here? In B6 deficiency, will iron be used to form heme?
No. It's the last step, right? So if you don't have B6, you can't form heme.
Yes, you can't form heme. So iron will not be used up. So what happens? This iron get deposited around the RBC as a ring. This is known as ringed sideroblast.
Oh,
So
okay.
that is
So that's
how.
what sideroblastic anemia.
Yes, that's why. Yes, you also have a good weekend, and I wish you all good luck. That is known as sideroblastic, right?
Thank you.
Yes, yes. Anything else? Any other question? You're welcome. Any other question? Anyone has any confusion with cancer genetics? Great. Everybody's good? Great. We will see you on, you said right to me. Did you say 8?
Sunday
Yes.
at
Sunday 8, I'll do a quick 50 minutes recap for both vitamins and cancer genetics. This will be very consolidated. I will not bring all the slides. Folate trap. Okay, this is folate trap. Folate trap means, so in folic acid deficiency, because of low folate in the diet, that causes a problem, right? In B12 deficiency, folate in diet is okay, right? Right? Yes or no? In B12 deficiency, is folate okay in the diet? Nothing wrong with folate in the diet, right? So why then in B12 deficiency we have megaloblastic anemia? Because in B12 deficiency, folic